And if we think, so if the world's becoming increasingly urban, and we've got these stark differences in health experience already in place at that urban level, and we've got the inequities in the health experience in place, if we then put the layer, the overlayer of this expected climate change and environmental degradation on top of that, and we think about how we're building our cities around the world, it's not particularly clear, but it's the idea of building at the coast. The majority of our urban development is happening around the coast. And if we just think about China, the bubble's going on, but so that's 7 to 8 million people in urban low-lying areas in China. Volume of people at risk is incredible. So the overlay of environmental degradation on top of already unequal social conditions, I think, is about to exacerbate the health inequity experience in urban environments around the world. So what do we do about that? Oh, and let's see if it works. In the context of climate change, I'd found this image, and I think it's so powerful if it works. No, it's not doing. No. What would happen if that runs all the way through to 2100, and basically Australia turns red, completely red, all over the place. But if you think around the edges, it goes up to about a 4-degree change. So we've sort of, the expected climate-induced temperature increase of 2-3 degrees. We're trying to work within that to do something about the health effects. Australia is going to have some very, very serious problems. If this is just an average estimate, and the urban, of course, the majority of the population in Australia are living in the urban environments at the coast, where there's we've got the combination of the increased flooding up in the northeast and the increased temperature change. So that added stress, environmental stress, is about to affect. I didn't think New Zealand experienced heat stress, but people were saying this morning that you do. I don't know if it's to the same extent. So just a quick sort of flash through some of the inequities in health and sort of the added environmental pressures of urban living. So what are some of the areas that has emerged within the urban literature if we're going to do anything about health equity? Well, many of the issues apply urban and rural, of the social determinants, but one of the big challenges in the urban environment is that the complexity, the added complexity of urban living, the size, the density and the diversity, and how do we deal with that in an equitable way that's good for health. And then the various other conditions. And one of the key determinants, the key drivers that has emerged in the literature for urban health equity in low, middle and high income countries is governance and the nature of governance. I spoke yesterday around matters of power, the power play. You see in urban settings that power play having such a direct impact on health equity. So what might be some of the factors within the sort of the daily living conditions that affect health and health equity, and what might we do about them? So I want to pick up on some of these, and I certainly don't think we can think about urban health equity without thinking about it in the context of climate change, whether it's getting hotter or colder, for some places are getting colder, and wetter or drier. And we have, again, some of our earlier discussions, we have the opportunity of identifying the win-wins. If we do something about the built environment, it can be good for greenhouse gas emissions, it can also be very good for population health. A key globally, one of the big things, I don't know how this is in New Zealand, but the idea of slum dwelling still being a key determinant of health and of health inequities because of the nature of the daily living conditions. You can see how the proportion on this figure, the proportion of slum dwellings, this is from the most recent UN Habitat report. Previous estimates in Europe is about 66% of people living in slums. Depending on how you define a slum dwelling, I would imagine that that's actually a bit of an underestimate. But the fact that we have in sub-Saharan Africa 62% of people living in slums is one of the main underlying determinants of health inequities, of those communicable and non-communicable diseases. And this is a figure from a colleague in Kenya, where just within the slums in Kenya, this is from, I can't remember the name of the slum dwelling, but that's the health clinic, and very rarely is this particular health clinic doesn't have anybody providing any sort of service. So just access to basic health services, and if you, again, going back to the idea of the communicable and the non-communicable disease burden growing very, very quickly in low and middle income countries, with the provision of health service that's still in some of these slum dwellings really inadequate to cope. And we did some calculations within the Commission to say, okay, well, if there are all of these slum dwellings that exist around the world, what would it cost to upgrade, to improve the daily living conditions where very large populations exist? And it's really not that much in the grand scheme of things of what's been happening recently, globally. It really wouldn't cost an awful lot of money, and the idea is you can do it if you want to do it, just people haven't wanted to do it, as yet the government certainly haven't wanted to do it. And so we made a recommendation as to how that might be shared, and there have been, in some of the African countries, this sort of model has been applied and has worked very successfully. And many of you in the room, of course, know that planning and design, how the urban built environment is planned and designed, the transport system is planned and designed, has major consequences for health equity. And just how the shape of it is set up. I give it this example in terms of the obesity epidemic and the built environment. So if you go from the red circle to the green circle, this was your comment earlier on, how might a child get from the red circle to the green circle? Well, you would imagine that they should be able to walk through. There might be a little joining pathway from that house to the top house. In this sort of design, it's not. So there's three options. The child doesn't go to visit their friend in the other house, and so what do? They stay at home and are usually less physically, spend less energy. The second option is they get on their bicycle or they walk around, which is great, of course, for energy expenditure. Or the third option, which is becoming increasingly common, is that they're put in the car and they're driven around. So not only is there less energy expenditure for the child, but there's also greater fuel usage and emissions. From an equity, so not particularly good in terms of urban design and being, for the obesity epidemic. What these sorts of designs from an equity perspective usually mean is that there's very little public transport, there's very little public amenities, very few shops often, and this is not in this particular example, but that urban sprawl out to the edge of the cities, which is where lower income households often end up in that large sprawl with few amenities. What that means for health equity, we know that that's a major determinant of health equity. So thinking about urban planning in such a way, I mean, all you need is a little lane to go from one house to the next, is it that kind? And just making a connection again in relation to transport being physically active and health amongst urban dwellers, but also that energy use and the correlation between urban sprawl, greater private vehicle use and greater energy consumption.